failing to understand that the first come, first served principle does not work in a pandemic like this can lead really catastrophic consequences.
Hello, I'm Katrien Devolder. This is Thinking Out Loud, conversations with leading philosophers from around the world on topics that concern us all. This is a special edition on ethical questions raised by the corona pandemic. In this video, I talk to Dr. Marco Vergano, intensive care specialist in Turin, northern Italy. Dr. Vergano is also first author of the recently published Clinical Ethics Recommendations for Allocating Intensive Care Treatments when Resources Are Limited. In other words, recommendations about who to give access to potentially life-saving treatments and who to let die. You worked during the night, so
yeah, and I'm working tonight as well. So I'm between two night shifts. Yeah,
wow.
Yeah, and I slept 1 hour after lunch today.
Wow.
It's okay.
Maybe to start with, could you describe a little bit the current circumstances in your hospital?
The situation is changing almost every day.
Okay.
For sure, every week. We started a little less than 1 month ago to admit the first severe cases of COVID-19 patients, so in my ICU. And now after a month, it looks like really some commentators, they say that 1 month of COVID life equals to probably a couple of years of normal life, because you learn a lot of things and things changes so quickly that it's really, when you think about your previous 2 weeks, it looks like really a very remote time in the past. When we issued this recommendation with the Italian Society of Anesthesia and Intensive Care at the beginning of March, the situation was already an emergency in some so-called red zones in Lombardia, in the areas around Milan, but still was manageable in Piemonte, where I live, in Turin. Now we are very under pressure, and we worked a lot with really huge efforts in order to increase our ICU beds capacity and also hospital ordinary ward beds capacity. But still we are admitting more and more patients every day. But the situation still is not so difficult and compared to Lombardia and compared especially with some hospitals in some provinces in Lombardia.
So you mentioned the recommendations. Can you give us a little bit more insight on these recommendations?
Well, it's a pretty short document, and with an introduction and then 15 short recommendations. So just a few pages, because also our aim was to develop a tool that could be easily accessed by colleagues in a time where your personal time is really very limited.
What did the recommendation say? How to decide between patients? Presumably it's not on a first come, first serve basis.
No, that's exactly what we wanted to avoid, because an usual attitude in admitting patients to the ICUs in a pandemic like this would result in saturating immediately your ICU with very old and frail people who are the most vulnerable, who are the first who get sick with a severe form of COVID-19 interstitial pneumonia. And you are probably able to keep them alive for many days or for weeks, because we have a lot of know-how and technology and skills in order to do this. But it's very unlikely that those people will survive to the ICU because they are too severe, and because we learned that this severe form of COVID-19 is really deadly for elderly, frail people. And while you keep them alive without reasonable hope of recovery and survival, the risk is that many more people with much greater chances of survival will die outside of your ICU door. You have to understand that you are responsible in a pandemic, not only for your single patient that you admitted, but also for everyone else that is outside of your door, and that probably will not receive an intensive care treatment and a life-saving treatment. These 15 recommendations, they set some triage criteria for the admission to the ICU, and also for the withdrawal of life-sustaining treatment. The principles used are basically the same over some past documents by our society, with a different threshold. Okay. So we stated that a combination of functional status, age, chronic illness, and frailty in general, combined with other steps like, for example, the surprising question, asking yourself or your colleagues, would you be surprised if your patient would be dead in just a few weeks or a few months? Just as a trigger of your approach and your decision-making process. And so we use these principles that are shared in the medical literature all over the world, and just with more focus on the need to be very stringent in your criteria, and to focus on the shortage and under this exceptional shortage of ICU resources in this current pandemic. So, but the principles are the same. So many critics of our recommendations criticize and accuse us of being discriminatory, unconstitutional, ageist, without realizing that modern medicine and intensive care medicine in general is already full of priorities and prioritization of patients, transplant medicine, and access to emergency departments. What changes here is just the general framework and the scale of this, because this does not involve just a few recipients of life-saving organ transplants, but maybe a large part of the population. So the criteria are the same, but the threshold could be a little different and is flexible and must be flexible. And the people involved are many more. What I would like to underline is that it is a clinical decision before being an ethical decision, because if you think that admission to the ICU is inappropriate because that patient has really unreasonable chances of survival, it is not a value judgment, or it's not deciding to save just a young patient because you think his life is worth more than the life of an elderly patient. It's just because he has much more chances of survival from this severe form of COVID-19 pneumonia. And also, not only he has much more chances of survival, but all things equal, you save much more life years. So I know this is a hard statement, but failing to understand that the first come, first served principle does not work in a pandemic like this can lead to really catastrophic consequences.
It's a bit of a controversial question, I think, among ethicists, about whether healthcare workers, doctors and nurses and so on, should get priority access to potentially life-saving resources, because after all, they are needed to keep other patients alive.
I think we should get a priority for testing, and that the safety of the healthcare staff in hospitals should be a priority for hospitals. I have to admit that, of course, this situation this is really heavy sometimes every day, because we have exhausting shifts and we doubled our shifts, and we have a lot of course, we have an emotional burden and colleagues that sometimes really collapse, and they need support by psychologists. And there are psychologists that probably will need support by their colleagues, because we will need psychologists for psychologists. And when you treat your colleagues in the ICU or in high dependency units, colleagues that of your age and that were working with you the previous week, sometimes you are scared and you think that maybe your roles could be easily exchanged in just a couple of days. But we strengthened a lot of our connections, our sense of belonging to a community of healthcare workers and ICU specialists and doctors, nurses. Even if we don't have an official priority, everyone knows that if one of us gets sick and needs an intratracheal intubation, for example, will remain in our hospital. So we will try to do that extra bed and just for us, because this gives you a sort of safety net, not only because you have access to a bed, an ICU bed, but also because you know that your colleagues that are your friends and in a certain sense your brothers will take care of you. So, and we will not be transferred to another hospital 200 kilometers away from your hospitals, because our hospitals are becoming a sort of a house in their home.
Because you spend so much time,
and I have colleagues that try to protect their families, and so they do not even go home between shifts. So it becomes your home. In all senses.
That's tough.
It is one of the less criticized recommendations, but I think one is becoming one of the most important things. Is the focus on the moral injury of healthcare workers, moral distress, and burnout, not only physical exhaustion but also emotional and moral exhaustion, because when you have to face hard allocating choices for many weeks or for months, of course you will need support, because you will remember a lot of faces of patients that you were not able to treat, and so this becomes a real burden, and that makes the difference. Also, I got a little bit angry with some commentators in Italy, because I think there's a real difference between some armchair philosophers and not being I mean not in your case, because not because you're interested in the reasons of the recommendations, but people that started criticizing and with very harsh criticism and with really venomous words and terms, without even be interested in asking our reasons. That is really difficult to bear. And because the main difference in that we try to reflect on these principles and treating these patients at the same time, and it's not the same as just reflecting on the principles and then having someone else. Nobody of us would like to be in a trolley problem scenario with the trolley with the lever in your hand.
Exactly.
And the people that they were still negationists of the severity of this epidemic. They didn't want to make a choice, pull the lever or let the trolley just go. They just refused that you could be there. So refused the idea that you could be in a position of having to make these choices.
It's like they're denying that there's a scarcity of healthcare resources.
The existence.
Whereas that is just a simple fact. I mean, that is a fact.
Or try to find unrealistic solutions, like for example, let's build or buy 5,000 ventilators, because people do not understand that a life-saving treatment is not just a bed and a ventilator and a couple of syringe pumps. You need skilled professionals. They do not get sick, and they are able to treat you for weeks. And you cannot just build these resources, human resources, from scratch just in a few days. So that's what also was misunderstood by many commentators in Italy.
Do you think Italy and other countries will be more prepared for the next time there will be?
For the next one, for sure. We are learning things week after week. Clinical treatments, experimental drugs, and ventilation strategies. We are sharing a lot of information these days. We have weekly webinars. We have networks with colleagues from China, United States, UK, everywhere. And because we are learning very quickly, and this changed completely the speed also of the sharing of medical information and scientific information.
Yeah.
We are learning a lot for the next one.
Thanks so much for sharing your thoughts on this.
Thank you.
And I hope the situation in Italy will improve very soon. And I also wanted to say how extremely grateful we all are, of course, for all the work that you do. And I'm sure the people watching this video will be extremely
thank you so much.
Grateful.
I hope that the situation in the UK will not reach the intensity and the severity of our. So I really hope.
Yeah, thank you.
Yeah, okay. Thank you very much.
If you liked this video, don't forget to subscribe to the Practical Ethics channel and the Thinking Out Loud Facebook page.